Thanks for joining us today for the next uh, webinar for Certified Lymphedema Therapists from the Boston Lymphatic Center. So the focus of today will be a discussion of really how do you go about thinking about when a patient may be most appropriate for referral for consideration of surgery and what can be done beforehand to optimize them for surgery. So we'll all kind of give a little bit of a chat here. I'm going to start with just a basic introduction, and then you'll hear from Emily, and then Dr. Singhal will hopefully join us at the end to kind of have more of an open discussion of how he approaches these patients from a more surgical perspective. So Emily, you can go to the next slide. So just, I think I've shown this slide before. It's just to make sure everyone's on the same baseline understanding of how we, as of now, appreciate lymphedema and its pathophysiology. So here's kind of a zoomed in view of a lymphatic vessel. And what happens over time as the interstitial fluid accumulates and lymphatic fluid starts to be stagnant in the tissues is you get an inflammatory reaction. And this inflammatory reaction leads to a thickening of the basement membrane. It leads to decreased functioning and fibrosis of the lymphatic vessel itself. And then as the process progresses, you start to get adipose deposition. And that's really vital in understanding how we approach patients, both from a pre-surgical and ultimately with surgical recommendation. As there is continued fibrosis, adipose deposition, worsening inflammation, you get skin thickening, and you get that firmness that you see on exam for more advanced cases. And we believe this is cyclic, meaning the more deposition of fat, more inflammation, you get worsening lymphatic dysfunction, which perpetuates the cycle further. You can go to the next slide, Emily. So this is, I've showed this last time when we were talking about the relationship between obesity and lymphedema. Here, again, is just showing how much adipose tissue on a cadaver slide of a patient with affected lower extremity lymphedema. And if you go to the next slide here, Emily, you'll see we use this. Obviously, we're not going to take a biopsy or cross-section of tissue, but we could see on MRI, very similar view on the left side of your screen is making the fluid bright, and on the right side of the screen, making the fat bright. And you can see there's a significant degree of both fat and fluid in this patient with left lower extremity lymphedema. Go to the next slide, Emily. So just a basic overview of when we're talking about surgeries, what are we offering? And the goal of this is not to go into the nitty-gritty of each surgery, but rather to have an understanding of what the potential options are. So they're going to put them into two buckets. So your physiologic procedures, your LV bypass, lymphoveno bypass, and lymph node transplant. The goal of those is to improve the lymphatic function and decrease the fluid in the limb. The kind of second bucket is the debulking surgery, primarily liposuction, and that is to remove that fat that's accumulated over time. And you can see based on this kind of very simplified chart, LV bypass, lymph node transplant do reduce symptoms. They can reduce volume, but it's more of a modest reduction in volume because you're not going to get rid of that fat accumulated. So if you have a patient that has a lot of fat, really you're going to get more dramatic reduction in symptoms and volume with liposuction first, and they can consider a physiologic procedure thereafter. Go to the next slide, please. So, we've moved a little bit. When Drew and I started working together 6-7 years ago, we were really limiting our assessment of patients that may be good surgical candidates to those that had advanced disease. We felt like their quality of life was affected enough to consider maybe doing something more drastic like surgery. But we've shifted away a little bit from that to say, well, maybe we should be catching these patients early. Well, let's not wait until that fat and inflammation and skin changes become out of hand, but let's catch them early before the fat starts to accumulate. Obviously, we're seeing patients later that already have that fat and considering them for liposuction, but there may be a role of catching these patients early. And this is our general approach to patients. Are they fat dominant based on exam and imaging, or are they fluid dominant? If they're kind of mild fluid, minimal fat, then maybe a lymphoveno bypass, which is generally just a day surgery, may be an option. If they have more significant fluid, then a lymph node transplant. That's a bigger surgery where they have to remove lymph nodes from around the stomach and move it to the limb. Patients are generally in the hospital for several days, and it's a longer surgery. And then you have, if they're fat dominant, that debulking surgery, like I mentioned before. But again, maybe if we can catch these patients earlier in that green square, we can avoid their need for bigger surgeries, and certainly more importantly, avoid their progression to a more advanced disease state where they have more significant symptoms. So this is evolving, but this is a general framework of how we're thinking about patients when we're considering maybe surgery and who may be an appropriate candidate. So this is more from a medical perspective, and Emily's going to go in her approach from a therapy perspective.
Okay, so now that you all have a sense of kind of the surgical options and which kind of like patient phenotype might drop into like what that patient might be most appropriate for from a surgical standpoint, I'm just going to focus a little bit on therapy's role in all of this. And I like to show this slide because this is our algorithm basically for how a patient might flow through our clinic. And I like to show it, especially to therapists, because I think it's really nice to see like us as therapists, we're pretty integral to this whole process. No patient is taken to the OR or even considered considered for surgical intervention until they're seen by therapy, or really everyone in the team. But we're kind of one of the key like aspects of the process in order to kind of give the green light for a patient for candidacy for the surgery. What isn't shown on this slide is how our therapy team is supported by our patients' like local go-to therapists. We're in the middle of the city. We realize that people are coming to us from, way out in the suburbs or even out of state. And we lean quite a bit on our patients' like home therapists quite a bit through this whole process. And I'll talk about that in a little bit going forward here. So the question in our clinic is always asked by the surgical team to us is like, is the patient ready to go for surgery? Are they optimized? And kind of what we mean by that is, does the patient have a self-care regimen that enables them to be stable on a day-to-day basis? In terms of their symptom burden, in terms of their amount of pitting edema, are they able to kind of maintain pretty even keel over time without fluctuating wildly in different scenarios, that kind of thing. Another kind of benchmark that we use is we try to keep our patients in that optimized category under 2 millimeters of pitting or 2 millimeters of pitting depth of edema or less. And so for these patients, like what can we do to get them there? And of course, our gold standard is CDT. For some people, though, they've been managed by a local therapist for a long time, or maybe they haven't, but they're actually in fairly good shape. They just need some tweaking from, they need some other tools in their toolbox to help manage them and get them to a place where they're really able to maintain that stability. So just tweaking their garment type, getting them to a custom flat neck compression garment where some people have never even heard of such a thing. Oh, that was never brought up to me as an option, or, something like that. So just minor tweaks can really make a big difference and kind of get them to where they need to be for getting them ready for surgery. And some of it's like a little bit different, like thinking out of the box. We've seen a lot, for example, in the past year or so about patients using texture underneath their compression pumps and getting a big hit on their decongestive benefit, as well as like fibrosis management and all of that. So just different things you can do to kind of tweak their self-care regimen to get them to be optimized and really ready to go from a surgical standpoint. Or not, some of these patients, most of our patients who come through the clinic actually don't undergo surgery here. I think it's like under 20%. Brett, you might have a better handle on that number, but some patients are, of course, just managed conservatively, and this is probably a good goal for any of our patients. So just from lymphatic surgery, kind of the implications for therapists on an outpatient side, kind of pre-operatively, of course, we're doing that whole optimization thing. Can we get the patient a little bit further or a little bit tighter control? We're educating them, of course, if they are interested in these surgical interventions, what the post-op expectations are, and specifically, what garmenting protocols might be, because that can be a lot for them to wrap their head around. I'll go over that in a minute. And then for our debulking patients, we're doing their like final pre-operative measurements to kind of get a final pre-op baseline before surgery on their limb volume, their bioimpedance, their quality of life, all of that. But also doing their final pre-operative garment fitting, which is essentially we're measuring them to be fitted for a garment on their uninvolved limb that they will come out of the OR wearing post-surgically, because our goal is, of course, symmetry for that procedure. So just briefly, we talked about these I just kind of want to talk about these briefly, just so that you guys have an understanding of some of the expectations for post-op. So for the surgical debulking, I mentioned that the patient basically comes out of the OR wearing their garments, and they're hospitalized for about 3 to 5 days. And this is a big one for some patients. The garmenting expectation, it can be a pretty big departure from what they're doing when you first meet them. They're basically wearing a class 3 and a class 2 garment during the day, and they're wearing that class 3 only at night. So it's a waist high 1.5 leg with a thigh high on top of it. And then they take that thigh high off at night, do their nighttime routine, whatever, but they're wearing that 1.5 leg at night. For the bypass, it's actually a day surgery. It's a less invasive procedure, less it's a less invasive procedure for these patients. They're bandaged in the PACU before they leave, and then they're back in their regular post-op garment or pre-op garment routine afterwards, starting on post-op day 1. For the lymph node transplant, most of these patients are getting a lymph node or a few lymph nodes harvested from their omentum. And so they have 2 surgical sites, the limb that's in question, of course, and then the harvest site. So good to keep that in mind. They're placed in a splint on the affected limb for 2 to 3 weeks to limit the range of motion and pressure on the flap to make sure that it gets really good blood supply and is able to kind of establish itself. They're hospitalized for around 3 days, and then they actually are out of compression for about 3 weeks. At the 3-week mark, they come back into the clinic and we make sure that they can fit back into their garment. And if they cannot, we'll bandage them. We'll do a multi-layer bandaging system until they do. We've actually not really run into that hardly at all in my experience. So it doesn't surprisingly happen more often. So on the outpatient side for follow-up, after surgical intervention, these patients are followed up at the 3-week mark for those lymph node transplant just to get their garment back on, but everyone else is followed at the 6-week, 3, 6, 9, and 12-month post-op marks for that first year. And of course, we want to make sure for every patient that their garments are kept up to date. So we just kind of like to tell people as a benchmark, just every 6 months, you should get a new set of garments. And then, you know, for a lot of our patients who live further away or they're coming from out of state, we don't expect them to come back for every single one of these appointments for their measurement check-ins and kind of to tweak things. So this is where we really lean on our patients' local therapists to kind of help us with this. And there's a lot of communication back and forth between our therapy team and the patient's local therapy team with like updating measurements and sending all that forward, or we had trouble with this post-op garment. Can you help us with that? Or something like that. So oftentimes we're able to do like a hybrid follow-up schedule, which is nice for the patient. And it keeps their local therapist really involved, which is great too. So for any therapist who's following up with these patients post-surgically, for the debulking patients, we're kind of focusing on the maintenance of that limb volume reduction, making sure that the garments are fitting, the patient's tolerating the post-op garmenting protocol well, tightening the garments up as needed, because oftentimes that initial garment is kind of an estimate because we can't measure for it in real time. So sometimes it has to be tweaked, and we kind of work on that over the first few months post-surgically. For the lymph node transplant, the goal is for stable or improved symptoms in that first few months post-operatively. And at 1 year, if a stability kind of in those objective measures and the symptoms has kind of been achieved, like their limb volume is fairly stable and their bioimpedance is kind of leveled out, we can try to attempt a controlled wean of the compression to see if they tolerate that and respond well to it. So for the bypass, the goal is really improvement of local symptoms and ongoing stability of their limb volume. As Brett mentioned, there's not a massive, it's kind of a modest improvement in limb volume, if any, but their symptoms certainly do improve, less heaviness, things like that. So we're kind of really focusing on quality of life here for a lot of these patients and their symptoms. There is a potential for these patients to wean out of their garments, but it depends on how many sites you're able to get with the bypass and kind of what general area it's covering. It's just more on a case-by-case basis for each of those. So to kind of wrap up, like now that you have a full understanding of like what the surgeries are, who might be appropriate kind of from a phenotype, fat dominant, fluid dominant, all of that, you might be asking yourself as somebody who's treating these patients in the community, like which of my patients might be appropriate and like what kind of things do I need to kind of look for to make sure they might be ready to go for surgery. But from our perspective here in the clinic, we want to make sure that patient has a BMI or an adjusted BMI of 35 or under. And what I mean by adjusted BMI is some patients have a pretty profound limb discrepancy, volume discrepancy, that can kind of tip the scales in terms of like maybe their BMI is at 35 or 35.4, but their limb weighs, 4 pounds heavier than the opposite limb. So we are able to use some of our bioimpedance tools and body composition tools to help kind of adjust their BMI to get them in the right range. Are they optimized? We've talked about this. Basically, compliance with a self-management regimen that is able to keep their pitting edema pretty minimal on a regular, stable basis. Is the patient able to tolerate the expected post-op compression protocol? This is a big one because for the debulking, our post-op protocol is pretty significant. And so people kind of have to understand that this is not like an optional thing. We want to make sure that the only way we can guarantee our post-op outcomes is if people follow the protocol, because we know that it works. So that's kind of a big one for people to wrap their head around. Realistic expectations. So basically educating our patients of what to expect post-operatively, yes, with the compression regimen, but also like, what is my limb volume going to do? Is it going to feel lighter? Is it, those kinds of things. So making sure they kind of have a good understanding of what to expect in the post-op period. And then their ability to follow up. If I have a patient who comes in and they're like, yeah, I'm not ever coming back here, it might not be the right fit. We have to make sure that we're able to track these people and guide them through their post-op experience. We're not like a do surgery and see you later type of place. So we want to make sure, again, that even if it means kind of splitting the follow-up between local therapy here, all of that, we want to make sure that we're able to keep track of these people and help them through anything that might kind of arise. So this is kind of where I thought we might have a little bit of a discussion. Basically, is my patient appropriate for a referral to a surgical center for any one of these procedures? And as Brett mentioned, it's not just these like super late stage lymphodemas that you're like, these limbs that are really difficult to manage and you're kind of stuck and want to know what your next step is for that patient. But it could be these earlier stage folks as well. And also some difficult cases, like patients who have difficulty with tolerating compression, or patients who have recurrent cellulitis and you kind of don't know what to do with them. Like I think oftentimes just a referral to a center that has access to like the imaging tools and the kind of full workup might help elucidate some of these things for a patient, regardless of whether or not they're a surgical candidate. But I thought we might have a little bit of a chat about different maybe patient scenarios that might be a question for folks, or I don't know. But I don't know if Drew popped on too, Brett.
Yeah, thanks, Emily. That's a great overview. Unfortunately, Drew just or somebody else called me. He is stuck in the OR, so he won't be able to hop on. But I'm happy to answer questions. As Emily, if anyone has any, you can put them in the chat or the question and answer section of the Zoom, or you can raise your hand and I should be able to unmute you if you want to come on and either give any of your experiences with patients post-operatively or concerns you have or questions about referring or timing or different situations. We're happy to try to address those. I'll ask you a question, Emily, while we wait to see if any others come in. Obviously, we share a lot of patients and see them almost back to back, and sometimes you get a different response or excitement level towards surgery that I did during my visit. What do you feel is kind of the biggest barrier when we feel like maybe they are a good surgical candidate from a pure kind of medical perspective? What do you think on a kind of more of a personal side tends to be a barrier for patients, or what pushes them back away from surgery or limits them from being a good candidate from your perspective?
It depends on which surgery. I think like sometimes, I think one of the things is that people come in, they're like, I want a lymph node transplant. And I think that sometimes they don't have that full understanding of the expectation of like their outcomes post-surgically. I think they're hoping that a lymph node transplant will fix their lymphatic system and that their, all their symptoms will resolve, including limb volume. And that's oftentimes, as we know, because of the fat deposition, that's not the case. So I think they're oftentimes like in the moment taken aback, like, oh, okay, so I have to have 2 different surgeries potentially. And like what that timeline might look like. Also for the lymph node transplant, we know that the real benefit can happen up to a couple years or 3-4 years down the road as the lymph node transplant actually proliferates its own vessels and kind of is able to implement itself into the kind of system within the limb. So the timeline can also be like a surprise to some people as well. I think that's one of them. But I think the biggest, most consistent concern that I see is for people who want limb symmetry. And I physically show them what the garmenting looks like, and it's very different from what they're used to. I think that can be like a big aha moment for them, like that they really need to sit down and make a decision of if they're going to be able to kind of tolerate that and what that might look like for their kind of life, working that into life and their activities and what they need to do.
Yeah, I'm also surprised that sometimes the patient's desires for surgery, we'll see some patients that have very mild edema and what appears, on the spectrum of what we see to be a mild case, and they're really pushing for surgery. And then we'll also see the contrast of patients that have severely increased limb volumes. They're doing a lot to manage it, but surgery just isn't something of interest to them. So what we really try to do and what we've learned over the last few years is trying to find what is going to meet the patient's goal. And if it's improved volume reduction, if it's getting them out of compression, if it decreased the frequency of infections or the associated symptoms, and trying to hammer down what are they going to get, or what are they hoping to get out of surgery, or our evaluation at the center, and how can we best meet that? And I think that's ultimately really what our goal is. It's not to always get the limb as small as possible or get them out of compression. It's really what is the patient's goal and what are they trying to do, and how is the lymphedema affecting their life? Because it's very different for different people and patients. So try to personalize it as much as possible, or however it fits into the algorithm. And I think we're pretty upfront with them that our understanding of who's going to benefit from what procedure is still a little bit limited, just in terms of the world's understanding of lymphedema and the role of these surgical procedures is rapidly evolving and constantly trying to do better. But I think at this point we have a good understanding, but we certainly have a lot more to learn in terms of who is the best patient for what type of procedure. Though we do a lot of imaging, which we didn't get into, and we'll have a separate webinar on the variety of imaging, but we do MRI, like I showed, to evaluate fat versus fluid, make sure there's no proximal venous obstruction, and then do a nuclear lymphoscintigram, which looks at the global lymphatic function, an ICG lymphangiogram to look at more of the detailed anatomy and see if they have some channels that may be appropriate for a lymphoveno bypass, and then follow-up imaging with a high-frequency ultrasound, which is a very detailed ultrasound that can actually visualize the lymphatic vessels and see how are they correlating with the vein, and do they match up where maybe a lymphoveno bypass may be appropriate. Again, I'll try to fit that into the context of what the patient's goals are. So let me see if we don't have any other questions. Again, feel free to put them in the chat or raise your hand if you have any. Emily, any other kind of closing comments or thoughts? When you see a patient, if you say, usually we're seeing them together, or I see them first, our team, but when you see a patient first, what is the biggest thing that says, well, I think you'd be a good surgical candidate?
Yeah, I think it's like I think for most of my patients who come in, they've had this like kind of circuitous trajectory with their lymphedema, just like finding their diagnosis and finally, finding the right therapist to kind of be in touch with. And I feel like by the time they oftentimes make it to us, they're like, they've done it all. They're like, yeah, I've tried the pump. It maybe was great, or it maybe wasn't, they've kind of ticked all the boxes in terms of at least trying out different modalities and seeing what's worked and what hasn't. But really just like consistency with something that works at least somewhat for them. It tells you that the patient is really like invested in the process and that they've really done their best to get to a place where they're able to make this more manageable. It's the patient who's like, yeah, somebody told me to wear a sleeve and I did for a little while and then I didn't really know if it was helping. So so it can be tricky, but I find the people who are like, yeah, I've done this, this, and this, and oh yeah, I tried that one time, but it wasn't really the best thing, but I've really stuck to something consistently. Even if it's not the best thing for them, they're like, this seemed to be the best thing for me and I didn't know what else to do. So I kind of just rode the wave. That to me is like speaks volumes about, gosh, this person's been through a lot. But they're kind of like, I think they're ready for like the next step, and they're open to suggestions and trying different things to kind of get them to the place where they need to be.
Yeah, I think, like you said, having their expectations be what we think we can potentially get, and having them show that they're dedicated to the care of their limb allows us to be a little bit more comfortable in moving towards surgery. And like Emily said, really only a minority of the patients we see in lymphatic medicine clinic and in therapy ultimately go to surgery, either because it's not right for them or we don't feel like it's appropriate, or they have multifactorial edema, which is very common, or they're obese. So there are a variety of barriers, but we're happy to see patients, again, the majority of our practice in patients that are not good surgical candidates, and helping guiding therapy or management of some of their concomitant issues as well. So we'll wrap up there. I don't see any questions in the chat. Feel free, as always, to reach out to us. Our contact was in the initial email for the webinar. Our next one, we'll plan to take a little break over the summer, and we'll be back in the fall with our next topic. So everyone enjoy their summer. Thanks for hopping on, and again, reach out with any questions if you have them. Thanks so much.